Among the serious adverse effects of SSRIs is an increased risk of major bleeding, including gastrointestinal and intracranial bleeds. For those patients taking SSRIs alone, without other risk factors, the absolute risk is relatively small. But what if your patient is also taking an oral anticoagulant medication, such as warfarin, or one of the newer direct oral anticoagulants, such as apixaban or rivaroxaban? Luckily, a new meta-analysis has combined previous studies to assess the increased risk of major bleeding in patients taking both an SSRI and an anticoagulant medication. Hi, Paul Zarkowski here with the Psychopharmacology Institute. The authors focused on major bleeding defined as bleeding that requires hospitalization or transfusion or a decrease in hemoglobin of at least 2 grams per deciliter. They searched for clinical trials and observational studies assessing the risk of major bleeding in subjects taking concomitant SSRIs and oral anticoagulant medication. They did not find any randomized clinical trials, but did find 14 observational studies, including 7 cohort and 7 nested case control studies. After discarding 6 studies with outcome measures that could not be pooled, the authors were left with 8 studies to combine in a meta-analysis with a total of 98,000 patients. The authors found an increased hazard ratio of 1.35 of major bleeding with the addition of an SSRI to oral anticoagulant medication. This elevated risk was significant, with a confidence interval of 1.14 to 1.58. To interpret this 35% increase in the risk of a major bleed, it is helpful to consider the baseline risk in subjects taking only warfarin, in which the annual incidence of a major bleed varies between 2 and 5%, with the incidence for a fatal bleed between 0.5 and 1%. The variability in risk of a major bleed is dependent on several factors, including advanced age, female sex, poor control of anticoagulation, history of bleeding, hepatic or renal disease, and other medications. Warfarin has been largely replaced by newer direct oral anticoagulant medication for the most common indications, including non-valvular atrial fibrillation, venous thromboembolism, offering similar to improved efficacy without a requirement for routine coagulation monitoring. These medications are direct in the sense that apixaban, edoxaban, and rivaroxaban directly inhibit clotting factor 10A, while dabigatran directly inhibits thrombin. The risk of a major bleed is significantly lower with apixaban, edoxaban, and low-dose dabigatran than warfarin, with no significant difference with higher-dose dabigatran or rivaroxaban. As direct oral anticoagulant medication has become the preferred choice in treating the most common indications, the authors added a separate secondary analysis to determine the risk of a major bleed in subjects taking concomitant SSRIs with direct oral anticoagulants. Based on 4 studies, the pooled hazard ratio of major bleeding increased to 1.47, with a slightly larger but still significant confidence interval of 1.03 to 2.10. The authors note that one limitation of the studies included in their meta-analysis is that most of the studies did not stratify for age. In the lone study that did, they found a significantly elevated hazard risk in subjects aged 75 or older of 1.95, but no significant increased risk for those under age 75. The same study also stratified for sex and found a significantly elevated risk of a major bleed of 2.06 in females taking concomitant SSRIs and oral anticoagulants, with a non-significant increase to 1.45 in males. As all 8 included studies were observational, there is a risk of bias due to residual confounding. The authors attempted to address this risk by assessing each study for adequate controls, along with other sources of bias. 4 studies with a serious risk of bias were removed, and a secondary analysis was performed in which the authors report their results were consistent with their primary analysis. It is very difficult to anticipate all the possible confounding factors in an observational study, as there could be some unanticipated clinical factor that increases the risk of major bleeding in patients with an indication for an antidepressant. For me, the most compelling evidence to address the concern of a confound by indication is the study that stratified for type of antidepressant. They found the risk of a major bleed was only significantly increased when SSRIs were added to oral anticoagulant medication, but not when tricyclic antidepressants were, in which the risk was nominally reduced. Although there could still be a confound in clinical factors involved in the decision to prescribe a tricyclic antidepressant or an SSRI, it is possible that the difference in risk of a major bleed is due to a difference in mechanism of action. As SSRIs specifically inhibit the reuptake of serotonin, they deplete the serotonin in circulating platelets by 80 to 90%. This deficit becomes apparent during platelet activation with less serotonin release, less platelet aggregation, and a prolonged bleeding time. Antiplatelet medications are a known risk factor for a major bleed in patients taking anticoagulant medication, as the risk of serious bleeding is the primary adverse effect in the prescription of anticoagulant medication. An additional increase of 35 to 47% with the addition of an SSRI is of concern. The authors do not suggest that clinicians withhold antidepressant medication in patients taking oral anticoagulant medication, yet caution is necessary, which includes an assessment of risk of bleeding based on other clinical factors including age, hepatic or renal disease, or a history of major bleeding. In those subjects with an elevated risk of bleeding, antidepressants with a lower affinity for the serotonin transporter should be considered.